Before we proceed to your pharmacologic treatment, punta muna tayo sa pwede mo na agad gawin when there is an event of premature contraction or preterm labor. For immediate preterm labor contraction, step 1, gagawin mo, allow the patient to void in order to give more space to your growing uterus. Number 2 is for them to lie left side lying, primarily to decompress the placental blood supply or blood vessels that supply blood on your growing placenta or on growing fetus, and drink extra fluid in order to supply more blood to your patient, primarily because preterm labor might be induced by restless fetus and discomfort. That's why you would like to supply more oxygen dun sa fetus natin by increasing fluid intake, thus increasing blood volume, thus increasing blood flow in the maternal fetal circulation, as well as lying left side. Punta na tayo sa tinatawag nating tocolytic therapy. When we talk about tocolytic therapy, basically the goal is to interrupt or inhibit uterine contractions and to create additional time for the in utero fetal maturation. So gusto natin mag-prolong ang pregnancy. That's why we proceed with tocolysis. The first tocolytic agent on our list is a beta-adrenergic agent named Terbutaline or Yutopar. It basically stimulates the beta-2 receptors of the smooth muscle. Thus, it decreases the frequency and intensity. Bumabagal ang contraction at humihina ang contraction. That's why Terbutaline is advised to be prescribed among our pregnant client experiencing preterm labor. Pharmacokinetics, route usually prepared is subcutaneous. It can be also provided intramuscular terbutaline. For longer therapy, oral route might be prescribed. For pharmacodynamics, usually the onset is already flashed in the screen. For pharmacodynamics, it will vary according to the dosage that you have administered to your patient or the route that you have chosen to administer that particular medication. Well, obviously, for oral route, it will take a longer time for the action to kick in. That's why usually for loading immediate action, in order to stop preterm labor, injection ang madalas na binibigay natin sa mga pasyente natin. The following are the common side effects of taking in terbutaline. Number 1 is tremors, body malaise or weakness, even dyspnea, tachycardia. And also, it might lead to increased systolic pressure, decreased diastolic pressure, chest pain, nausea, vomiting, diarrhea, constipation, erythema, sweating, hyperglycemia, and hypokalemia. You need to watch for the following adverse reaction. Baka magkaroon ng pulmonary edema, dysrhythmias, ketoacidosis, and even anaphylactic shock. When providing terbutaline to your patients, you need to understand the following nursing interventions or responsibilities associated to the administration of your terbutaline. Number 1, you need to monitor fetal heart rate and maternal contraction. Baka nagkakaroon na ng fetal distress due to prolonged contraction, or because of the administration of your terbutaline, there might be fetal distress as well. So always, when you are to administer a particular medication that might affect the condition of your child or that is concerned for the maternal health, always hook ang iyong nanay sa fetal heart monitor natin to check for contraction as well as fetal heart rate. Also, maintain the patient's position on a left lateral position. Auscultate for any abnormalities when it comes to your cardiac rhythm in relation to its side effect. Also, auscultate breath sound. Notify the provider if there is dyspnea or even tachypnea. Masyadong mabilis ang paghinga. That might be an adverse reaction. Now, due to an excessive increase in the rate of respiration, that might compromise the exchange of oxygenized air going to your lungs and exhalation of carbon dioxide. That might compromise also your fetal circulation, which requires oxygen during the process. That will further jeopardize the totality of the scenario having PTL. That's why you need to report immediately when tachypnea has been observed. Monitor daily weight to assess for fluid overload. strict I&O for patients taking in Yutopar and Terbutaline. Report baseline fetal heart rate more than 180, takip niya naman sa part ng baby. You are also to report increase in contraction with regards to the pre-treatment baseline. Baka hindi naging effective, dapat bumaba imbes tumaas. Report persistent contractions despite the treatment, hindi nagiging effective. Also, you are to report a leaking bowel, bleeding or rectal pressure. Ito na yung bumababa yung baby, which you do not like during the treatment. Adverse ang nagiging reaction or opposite. Also, report for heart palpitations, dizziness, and extra precaution when taking any other drug while on this therapy. That is your Yutopar or Terbutaline. Basic drug-to-drug interaction for Yutopar, ito ang dapat nyong tandaan. For anesthesia, because it causes hypotension, anesthesia also brings down different physiologic processes of the body. It might result to extreme decrease in blood pressure. That's why extra caution when you are providing Terbutaline. Also, when administered together with corticosteroid, it might result to pulmonary edema. Beta-adrenergic, yung mga may dulo na OLOL or OLOLs, okay? It antagonizes beta sympathomimetic effect. That's why you need to consider administration of Yutopar and Terbutaline together with these medications. Next will be magnesium sulfate. When we talk about magnesium sulfate, based from our discussion a while ago, it's considered to be a calcium antagonist kasi magkaiba silang effect. It is also a CNS depressant which basically relaxes muscle through calcium displacement. Kasi sabi natin, calcium contracts, magnesium relaxes. How magnesium relaxes a muscle? It basically displaces calcium. Kaya hindi nagkakaroon ng uterine contraction. Which is basically the problem for preterm labor. Nagkakaroon ng untimely contraction ng uterus. Kaya gusto nating pahintuin how we are to administer a muscle relaxant in the form of your magnesium sulfate. Your magnesium sulfate does not only relaxes the muscle of the uterus, preventing contraction, but another good effect of magnesium sulfate is that it causes vasodilation. In the event that there will be vasodilation, imagine a hose, lumaki ang butas, more water will flow. In our case, blood vessel, lumaki ang ating intravascular lumen. Okay, tendency, more blood can flow now on that particular vessel. Thus, it increases uterine perfusion, which will result to increased fetal circulatory volume or perfusion as well. Compared to Terbutaline, your magnesium sulfate is generally cheaper in a sense, which crosses the placenta. Magnesium sulfate titration is based on clinical manifestation, depende sa BP ng iyong client. It is considered to be a pregnancy risk category B drug. Onset of action, if it's provided IV, immediate ang action. Duration is 30 minutes. However, magnesium sulfate is contraindicated for the following patients. Number 1, for patients suffering from myasthenia gravis, primarily because it furthers the damage of your acetylcholine receptor, which is the basic problem for myasthenia gravis. Number 2, pag may impaired kidney function, how will you know? Determine your BUN and creatinine level. Magnesium sulfate cannot be excreted and might be toxic. Later, I will show you the signs and symptoms for magnesium sulfate toxicity. Also, for patients who have suffered from recent myocardial infarction, nagkaroon ng cessation or irregular cardiac contraction due to poor blood flow on your cardiac muscle. Tandaan, contraction ang palaging involved na electrolyte, dalawa, calcium, magnesium. That's why it's contraindicated for cases such as myocardial infarction patients. What do you need to remember when we are to associate side effects or common effects of toxicity for magnesium sulfate? Tandaan ang ating acronym na BURP. Ano po yung BURP? Letter B, basically decrease in blood pressure. That's why prior to administering magnesium sulfate, you are to hook the patient on a fetal heart monitor as well as maternal BP. Palaging tinitake ang BP. Habang nag-ongoing ang magnesium drip, pwedeng i-take ang BP ng pasyente because it might lead to excessive decrease in blood pressure among your patient. Later on, as we further our discussion, you will see that magnesium sulfate is also a drug of choice when we are treating a patient who is suffering from pregnancy-induced hypertension. Pero for the meantime, ang concern muna natin with regards magnesium sulfate is cessation of uterine contraction. Number 2, letter U, urine, or what you call oliguria, wherein the urine is less than 30 cc per hour. Konti. Problem ba yun sa kidneys? Yes. And as per what was explained, magnesium sulfate cannot be given for patients who are suffering from renal impairment. What will be your nursing responsibility when it comes to oliguria? Instruct the patient that you need to put a Foley catheter prior to provision of prolonged IV incorporation of magnesium sulfate. Primarily for you as the healthcare provider to adequately account and quantify your patient's urine. And letter R, respiratory depression. An RR less than 12 might indicate an adverse reaction or a sign of toxicity. And letter P, decrease in patellar reflex. Primarily, burp signifies a decrease in all of these factors, and the antidote for magnesium sulfate toxicity, syempre yung kontra niya, yung ina-antagonize niya, which is basically calcium gluconate. That's why a nursing responsibility when you are taking care of a patient who is being provided or undergoing magnesium sulfate therapy, always have on standby calcium gluconate in an event that there might be magnesium sulfate toxicity. During an event of preterm labor, we cannot exclude the fact that there might be imminent delivery. Kaya aside from treating the mother, we should also anticipate the maturity of different organs of the fetus during that particular period. Kaya importanteng mag-administer tayo ng tinatawag na corticosteroid therapy. I was asked before when I was a new or a neophyte nurse, what's the purpose of administering corticosteroids among patients? And I simply told them that's because you might be allergic to the drugs. That's an incorrect statement or an incorrect response. We are administering corticosteroid not for the mother but rather to promote fetal lung maturation. That's why it's used when the age of gestation is usually 24 to 34 weeks, wherein the lungs is still premature and we would like to hasten the maturity of the lungs by administering corticosteroids. It basically does this by accelerating lung maturation with resultant surfactant development in the fetus intrautero, sa loob pa lang. There might be increased or decreased risk for RDS among our clients when it comes to administration of corticosteroids. First drug for your corticosteroid therapy is betamethasone. When we talk about betamethasone, it basically hastens the production of your surfactant in order to prevent fetal lung collapse in an event that your fetus be delivered and be exposed from the outside environment. It's given at least 24 hours, preferably 49 to 72 hours before the delivery, but not less than 7 days before delivery in week 33 or before. Betamethasone is considered pregnancy risk category C drug, protein binding ability 64%. And the following details with regards to your betamethasone is posted on your PowerPoint presentation. When we are administering betamethasone, you need to consider the following because they are considered to be your contraindications. Number 1, when there is pregnancy-induced hypertension or fungal infection. Primarily because PIH, the only way on how to resolve PIH is for you to deliver the fetus. Now, if you are to prolong the fetus, might as well not provide betamethasone. And systemic fungal infection, primarily because prolonging the labor might cause jeopardy because this is an infection both to the fetus and to the mother. As what was explained a while ago, you cannot provide corticosteroid together with terbutaline primarily because of an increased risk for developing pulmonary edema. Kaya wag mong ibibigay. ng simultaneous. Not to be given for patients who have had premature rupture of membrane kasi nga in the first place, PROM patients are not candidate for PTL or PTL treatment or tocolysis. It basically crosses the placenta and enters the breast milk. That's why extra consideration for patients who are breastfeeding as well. Aside from administering corticosteroid, another pharmacologic intervention in order to address a poor fetal lung development will be administration or doing surfactant therapy. Surfactant is basically the substance that prevents lung collapse. That's why synthetic surfactant therapy is a second approach in addressing respiratory difficulties among preterm infants. We have two types. We have number 1, ExoSurf Pediatric. This is a protein-free surfactant for prevention of respiratory distress syndrome or RDS. It contains 13.5 milligrams of colfosceril palminate or DPPC, a major lipid component of a natural surfactant. Basically, we would like to mimic the surfactant which is present on a normal lung. Application intrathecal because upon delivery, itong mga surfactant therapy, unlike Betamethasone which are injected among pregnant clients in order to help fetal lung maturation intrautero, ito nasa labas na, na-deliver na, preterm infant na. That's why they are being intubated in order to facilitate or to assist them in breathing. That's why the mode of entry of this particular medication, ExoSurf, is through intrathecal route, okay, or intratracheal route. Your patient must be on a MEC-VENT prophylaxis treatment, 1 dose immediately after birth. Then, additional 2 doses at 12 and 24 hours for infants under MEC-VENTs. Rescue dose can be given as soon as manifestations of RDS had occurred or respiratory distress syndrome. 12 hours if patient is in MEC-VENT. Next will be Survantra intrathecal suspension. This is a natural extract from pigs, mimicking the component of our surfactants. Prophylaxis treatment, first dose should be given 48 hours of life, then every 6 hours. Give the first dose immediately, minutes and hours after diagnosing RDS. Usually, when you are providing Survantra intrathecal suspension, you might encounter that you are auscultating your pediatric client, then RALS or moist breath sound have occurred. Mind you, this is expected. No need to panic. This is no sign of obstruction or any discomfort. Do not do suctioning. Kasi expected kapag ka nag-Survanta tayo na magkakaroon ng RALS for your patient. That's why do not suction. Both of these interventions requires a patient to be on an ET tube. Position changes allow gravity to assist in the distribution of the product all throughout your respiratory system. That's why a nursing responsibility is that you are to change the position of the newborn every now and then. RALS and moist breath are expected. However, if there will be obvious signs of respiratory compromise, ibig sabihin nagkakaroon na ng bluish discoloration, cessation of breathing, or any signs of obvious airway obstruction, then by all means suction. But unless there be any, do not suction your clients. Okay? Suction should not be performed 2 hours following administration of that particular drug, primarily because you will be only suctioning that drug and will render it useless. Dosing is to be adjusted if, number 1, patient manifested a dusky color. Number 2, if the patient is agitated. Number 3, if the patient have experienced bradycardia or decrease in fetal and the neonate's heart rate. And number 4, if the oxygen saturation decreased around 85% or 15% less than its initial reading. Next will be managing PIH or pregnancy-induced hypertension. When we talk about pregnancy-induced hypertension, this is basically observed on an AOG 26 weeks above. That extends up until 72 hours post-delivery of the baby. Preeclampsia, this is the term we use to denote hypertension accompanied by proteinuria and edema during the 20th week of age of gestation. Eclampsia, on the other hand, is developed preeclampsia, usually due to the absence of prenatal care. So, depende. Also, when the patient is experiencing seizure, we are now able to qualify that as eclampsia, hindi na preeclampsia. You will learn more when you go deeper in your learning for your maternal and child nursing. However, you need to understand the HELP syndrome, that's hemolysis, elevated liver enzyme, as well as low platelet count. These are signs of what you call severe preeclampsia. Well, as of the moment, the main reason for pregnancy-induced hypertension remains to be unknown. The main cure is basically the delivery of the products of conception. Kaya hindi natin pinapahinto if the preterm labor is associated or accompanied by pregnancy-induced hypertension that might jeopardize your pregnant or maternal side health ng nanay. Okay, we do not prolong preterm labor because PIH is our primary concern. Because the only way, again, to stop PIH from occurring is to deliver the baby. The goal for pharmacological treatment will be, number 1, we would like to reduce vasospasm in order to relax our blood vessels, thus decreasing your blood pressure. And number 2, okay, prevention of seizures. During an experience of PIH, vaginal delivery is preferred. This is basically to avoid the complications brought about by anesthesia. For HELP syndrome, may have labor induction at 32 weeks AOG. Kapag ka nagkaroon na ng HELP syndrome, severe preeclampsia na, pwede na tayong mag-deliver ng baby as long as it has reached the 32nd week mark or the 8-month period. If eclampsia happened, postpone the delivery by 1 to 3 hours. If fetal status is still good. However, if it's imminent, CS delivery is an additional stressor that might cause acidosis, thus leading to further seizure. That's why our preferred mode for delivery for patients who are suffering from eclampsia or preeclampsia is still normal vaginal spontaneous delivery. So, what are the treatment? Number 1, magnesium sulfate. Kasi sabi natin kanina, magnesium sulfate vasodilates. This prevents and prevention and treatment of seizure related to PIH. It does not only relax muscle, but it acts as a CNS depressant. It decreases the acetylcholine from motor nerves, which blocks the neural transmission. That's why there is basically a lesser risk for seizure. That's the very main reason why it's contraindicated for patients who are diagnosed to have myasthenia gravis. Kasi myasthenia gravis, mababa na nga ang acetylcholine receptors. Tapos, pabababain mo pa ng magnesium sulfate. Kaya hindi pwede. Vascular dilation equals an increase in blood flow in your uterus equals an increase in maternal fetal circulation. Also, a good thing, it inhibits uterine contraction. Again, this is considered pregnancy risk category B, and the nursing responsibilities are the same compared to magnesium sulfate that was explained a while ago. I would like to add the following. Maintain the fetal heart rate between 110 to 160 beats per minute and always secure and check signs for magnesium toxicity, which is again burp, blood pressure, hypotension, urine, oliguria, R, decrease in RR, letter P, decrease or depression of your patellar tendon reflex. Next drug will be your hydralazine. It's an antihypertensive agent that is really potent, that causes immediate reaction in terms of the BP of your patient. Arteriolar vasodilation is the basic mode of action. That's why decrease in blood pressure is being experienced immediately after administration of hydralazine. The goal is for us to maintain a systolic BP between 90 to 110. And if the BP of your patient is already at 105 millimeters mercury mark, usually we are not giving hydralazine anymore. Madalas hydralazine, binibigay lang natin yan sa mga matataas talaga ang blood pressure natin. Okay? The onset of action, usually it takes 5 to 20 minutes. Peak of action, 10 to 80 minutes. Duration, 2 to 6 hours. Nursing responsibilities when taking or administering hydralazine. Number 1, always check heart rate. And number 2, BP. BP every 5 minutes. Okay? Because again, this is a potent antihypertensive medication that will require you close monitoring of the patient's blood pressure because immediately after administering hydralazine, there might be a severe or a significant decrease in blood pressure that might in turn alter the fetal maternal circulation or the maternal fetal circulation. Explain to the patient the need to hook the patient to a non-invasive blood pressure. Also observe for changes in the level of consciousness. Monitor fetal heart rate as well as patient's input and output. Now we have finished discussing medications that are administered during the pregnancy period. We now move to the labor itself. Nag-start tayo sa major complaint during the labor, which is basically pain. I would like to course you through the different phases of labor and delivery. Number 1, first stage. This is according to your maternal and child nursing. First stage is cervical effacement and dilation, usually to reach 10 centimeters dilation and 100% effacement. Second stage is during the time na mag-engage ng fetus up until the time of expulsion of the fetus. That's the second stage. Third phase is your placental separation and the expulsion of the placenta as well as initial recovery. And fourth stage is 2 hours following labor and delivery. Usually during those periods, there are different sources of pain among our pregnant clients that you need to understand. So what are the causes of labor pains? Number 1 is basically uterine muscle contraction. Contraction of the uterus itself causes pain, plus with the increase in the contraction of your uterus, that will require more oxygen. In an event that there will be hypoxia, it will revert or lead to an event of using or producing lactic acid due to anaerobic respiration. That's why it might produce pain as well. Number 2, cervical effacement and dilation. Number 3, bladder distension, vagina and perineum. Nagkakaroon ng palaking bladder that might impede your uterus. Okay, that's why when contracting you are now feeling pain. Number 4 is referred pain, and number 5 is psychological experiences due to trauma from previous delivery, anticipation, and even fear and anxiety. For non-pharmacologic relief, the following are advised among our patients. Number 1, palakarin or what you call ambulation. Number 2, positioning, position of choice natin, still left side lying position. Number 3, hygiene and comfort measures. Number 4, support from the significant others, because again, together with the mothers, the father of the child or the significant others might provide psychological effect, thus decreasing the sensation of pain among our clients. Deep breathing exercises and relaxation techniques are also advised during these scenarios, and hydration therapy. If pharmacologic intervention is required, consider drugs that does not only promote pain relief but also minimize the effects on fetus and the mother. That's why during labor and delivery, you need to hook the patient to a continuous fetal heart monitor as well as the mother being hooked to a cardiac monitor in order for you to continuously monitor both the mother and the fetal's health status. So mag-start tayo sa analgesia. When we talk about analgesia, these are systemic medications employed basically to control pain. Number 1 will be your sedative or your hypnotic. Your sedative or hypnotic given for false labor or latent labor or rupture of membrane. Ibig sabihin yung labor pa nila, Braxton Hicks lang. Hindi pa siya true labor. That's why you can allow the patient to rest a bit and charge up her energy in order to gather enough strength during or comes the time that they will be requiring the mother to exert effort to push the baby. Kaya pinapatulog pa natin sila sa hospital. Do not give this for true contraction, primarily because if you have sedated a patient suffering or having true labor contraction, tendency is makakatulog, wala ng active effort from the mother to push the baby. Tendency is you will have a hard time in delivering the baby via normal spontaneous delivery. Your sedative hypnotics basically promotes rest and relaxation by reducing fear and anxiety. It does not really promote pain relief. Pinapakalma niya lang ang pasyente. Sedative kasi siya. Do not give if labor is imminent, especially if you will require the patient to push or to exert some effort in order to push through the pregnancy. Observe fetal heart rate tracing. It is expected that there will be decrease in variability in terms of the fetal heart rate. However, always monitor for fetal distress and changes or significant changes in terms of the breathing and heart rate of your fetus. First sedative hypnotic is basically your secobarbital. It is given only if the delivery is not expected within 24 to 48 hours. So matagal-tagal pa ang delivery, gusto mo na magkaroon ng pain relief, secobarbital tayo. Basically, the side effect of this medication is paradoxically increasing pain and excitability. Lethargy, subdued mood, decreased sensory perception, and hypotension. Also, you need to monitor a significant decrease in the fetal heart rate and neonatal respiratory depression because depressants to mga to, sedative. So generally, you are to monitor this, sleepiness, hypotonia, hindi na masyadong naggumagalaw si baby, poor sucking response for additional 4 days. Your secobarbital is considered to be pregnancy risk category D, onset of action 10 to 30 minutes, peak of action 20 to 30 minutes, and duration of action approximately 4 to 8. Let's now proceed to another analgesic in the form of your athartics. Your athartics potentiate an analgesic effect of low-dose narcotic. That's why usually your athartics having a potentiation effect is administered together with a low-dose narcotic. It decreases anxiety and apprehension if administered via IV, give at the beginning of the contraction. Okay? Due to easy placental crossing. Administer this particular medication slowly and do not give this medication subcutaneously. Usually, the mode of administration, if not IV, will be intramuscular. Example of this is your promethazine. Your promethazine is an adjunct treatment for narcotic treatment. Ibig sabihin, usually it is being administered together with a narcotic. Okay? Also, it has an antiemetic effect that promotes rest and sleep. It decreases variability in the fetal heart rate, thus regulating fetal heart rate, decreasing the probability of fetal distress. Side effect, on the other hand, might result to maternal tachycardia and impairment in the newborn's platelet level. This is considered also pregnancy risk category C drug. Now, together with your promethazine, you are to administer a narcotic agent. The very goal of administering a narcotic agent is to promote rest or sleep, then wake up during the time of the active labor. Ito yung sinasabi ko na pagpapahingahin muna natin yung patients natin in order for them to gather enough energy comes the time that we will be requiring them to bear down and push to expel or to promote fetal expulsion. It interferes to pain impulses and the subcortical level of the brain. The secondary effect basically is sedation and increased anxiety. Consider parity of the patient and likely the amount of time until delivery. Do not give when delivery is likely to happen between 1 to 3 hours because, again, of its sedative effect. You need the patient awake and, forceful during the time that you will ask her to bear down. Okay? Monitor urine output, ensure fetal heart rate tracing in order to indicate fetal well-being before administration and during administration, and observe for changes in the fetal heart rate. An example of your narcotic agent is basically fentanyl. Fentanyl binds to the opiate receptors of your central nervous system. Thus, there is an alteration in terms of perception and emotional response sa pain. Talagang nakakatulog yung mga pasyente namin after administering fentanyl. Onset of action is very fast, 1 to 2 minutes. Peak 3 to 5 minutes. Duration is 30 to 60 minutes. That's why you are not to administer these kinds of medication 1 hour to 3 hours prior to delivery. Only trained staff are to provide fentanyl. The following are side effects for fentanyl administration: orthostatic hypotension or hypotension for that matter, nausea, vomiting, headache, sedation, hypotension, confusion. Monitor the following during the provision of your fentanyl. Okay? Decreased fetal heart rate variability and neonatal CNS depression. This is considered to be a pregnancy risk category C with a half-life of 3.6 hours. Generally, wag natin ibibigay ang ating fentanyl before active labor. Prepare naloxone, a narcotic antagonist, as an antidote in case there will be fentanyl overdose, because fentanyl is a CNS depressant. So everything, even from your maternal and fetal circulation, fetal side, maternal side, maapektuhan. That's why always check. Check for BP, heart rate, and respiration. Do not give if the patient is hypotensive, okay, bradypneic, and experiencing bradycardia. Also, because of the possibility of a sedative effect, anticipate that the patient might fall asleep. Always secure safety. Always elevate the side rails. Now, labor pains brought about by contraction of the uterus can be alleviated with the administration of, well, ang ating uterine relaxant, which is basically your magnesium sulfate. Magnesium sulfate compared to the other narcotics and pain relievers are less potent. Okay? Again, same considerations for administration of magnesium sulfate, which is basically the consideration of toxicity, burp. Aside from your narcotics, you also have mixed narcotic agonist-antagonist in order to balance out their effect. Okay? Meron kasi tayong tinatawag na ceiling effect, that an additional dose has no effect anymore and will not increase the degree of respiratory depression. Ibig sabihin, naabot niya na yung pinaka-maximum effect niya. Okay? May be sequenced with narcotic agonist, but narcotic agonist should always go first before mixed narcotic agonist-antagonist. Okay? Most narcotic agonist renders ineffective if otherwise was done. Example of which is Tadol, which basically binds the CNS opiate receptors, kagaya nung kanina sa ating fentanyl. And also, you are not to provide this subcutaneously. Standby naloxone, which is our antidote of choice in case there will be narcotic antagonist and narcotic antagonist agonist provision or excess. Kailangan palagi kami naka-standby na naloxone. It might exhibit withdrawal symptoms in narcotic dependent clients. You might observe withdrawal symptoms. Common in the hospital, however, is Novain. Major consideration for administering Novain is for you to check for respiratory depression. That's why always on standby, again, your antidote of choice, naloxone. Now we move to the medication that totally prevents the sensation of pain. Ito yung anesthesia na tinatawag natin. We have what you call visceral pain, which is basically brought about by the increasing in pressure in your cervix as well as uterus. You also have your somatic pain, which is experienced in your perineum vagina up till your S2 up until the pudendal nerve. Kaya may iba-iba tayong type of anesthesia which will be discussed one by one. Let's start with your regional anesthesia. When we talk about regional anesthesia, this is pain relief without loss of consciousness. Doon lang sa area nawawalan ng pain sensation. It temporarily blocks conduction of painful impulses along the sensory nerve pathways to the brain. Kaya localized lang, regional lang. It allows labor and birth with relief from discomfort on the blocked area. Okay? Also, another example is your local anesthesia, kung saan lang in-inject, doon lang nagkakaroon ng numbness. Next will be spinal block or spinal anesthesia, the basic indication of which is for high-degree pain relief, primarily for patients who are to undergo cesarean section. Ginagawa to sa hospital prior CS. Now, it's given immediately before delivery or even surgery. late and second stage when fetal head is already exposed. Area block is from the umbilicus down pababa, kaya the nursing responsibility is for us to explain to our patients that there will be numbing sensation from the area of insertion until the bottom area. That's why for prolonged or excessive or increased amount of spinal anesthesia, you need to consider putting the patient under or putting a Foley catheter in order to still promote adequate drainage of your urine kasi wala silang uterine control during that time. The area injection site is from lumbar 4 to lumbar 5 primarily in order for us to avoid the equinox and damage to the nerves. Consideration: given immediately after contractions to avoid respiratory depression. Position the client while providing sitting or curled side-lying position. What's important for you to understand when we are doing spinal anesthesia or even lumbar block, ang ginagawa natin, we are to inform the patient that the patient is to remain flat on bed for approximately 8 to 12 hours more in order to prevent spinal headache. Okay? Spinal headache is a type of headache that cannot be treated by simple analgesic. That is basically because of the changes or the shifting of your fluid or your CNS fluid na nangyari during the administration of your spinal block. Also, you have lumbar block. Iba lang ang injection site, T12 to S5, entire pelvis, rather than the spinal block. Your lumbar block only targets the epidural space. You are never to inject above L1 primarily because we are preventing any injury doon sa part na may equinox or may nerves. The goals is to bathe the nerves with dispersed local anesthesia. I-inject natin, actually hindi tayo but rather the anesthesiologist doing this. Lumbar block continues on the other hand. They will put a catheter inside which will enable us to deliver controlled pain relief. Ito yung tinatawag na controlled pain relief or lumbar or lumbar anesthesia. Alright? Another is what you call your pudendal block. Pudendal block is for outlet forceps or episiotomy repair. Okay? Ibig sabihin, na-deliver na yung baby during normal spontaneous delivery, pwede tayong maglagay ng pudendal block. This is immediately given after birth. The area that is being blocked is the pudendal nerves located in your perineum. The site of injection is inside the birth canal, deep into the lower sides of your vagina, to bathe the pudendal nerve with anesthesia para mag-numb siya doon sa area na yun. Next among our list for our discussion are medications that enhances uterine contractility. Kanina, during preterm labor, we would like to cease uterine contractility. However, during labor and expulsion of the baby, I need you to understand that there is a positive feedback mechanism that happens within the body, wherein there is an increased release of a particular hormone in order to promote uterine contraction. Kasi gusto nating ilabas si baby from our mother's uterus. That's why in order to support this, we are administering medications that enhances muscle contractility of your uterus. However, there are several considerations when doing this. The considerations for doing uterine muscle enhancer or contractility enhancer are the following. AOG, tama na ba? Nasa edad na ba ang iyong fetus that it will be able to survive the outside environment? Number 2 is fetal position. Mind you, aside from your consideration of an non-proportional fetal head and outlet diameter ratio, ibig sabihin sobrang kitid ng pelvic inlet compared to the head of the child, that might only cause pain, and excessive uterine contraction might injure not only the baby but also the mother. Another example, if your baby is lying on his or her back, then the pelvic inlet is just below the infant or the fetus. increasing cardiac contractility might further increase the pain and injure both the child and the mother. That's why dapat i-consider natin ang positioning as well as cephalopelvic disproportion or proportion. Also, there is what you call Bishop scoring in order to check for response in your induction. Bishop scoring is already provided on the handout that was given or handed out to you during our orientation period. Now, kung may consideration, meron din tayong tinitignan na reasons why we would like to proceed with your uterine enhancer contractility. Okay? Number 1 will be PIH because according to what I said, PIH, the only way to answer or to treat PIH is the delivery of the products of conception. Number 2 is chronic hypertension, which is typical for patients suffering from preeclampsia and eclampsia. Number 3 is for patients who have suffered membrane rupture for more than 24 hours because this increases again the risk for infection. Thus, we would like to facilitate delivery during that time. Chorioamnionitis or an experience of infection, post-date patient, post-date infant wherein the AOG is more than 42 weeks, lampas na siya sa panahon niya. Number 6 is uterine growth retardation. Number 7, positive contraction stress test that the patient or the infant or the fetus is experiencing discomfort during contraction, kailangan nating i-deliver. You also have maternal renal disease, RH, isoimmunization, which will be further discussed later on, and intrauterine fetal death. Because intrauterine fetal death, of course, the baby is already considered to be a waste product that might contaminate and cause sepsis to your client. That's why kailangan natin mag-induce ng labor. Again, I would like to reinforce what I have said a while ago. The following will be the contraindications for induction of labor. Number 1, there is cephalopelvic disproportion because this will not only cause increase in pain level but might cause injury both to the mother and the child. Number 2, unfavorable fetal position such as transverse or breech. Number 3, fetal intolerance that when there is contraction, nagkakaroon ng stress. Pagka ganon, ang option natin is to deliver the baby via cesarean section and not to proceed with normal spontaneous delivery. Number 4, prematurity. Obviously, we would not like to initiate delivery by initiating contraction if the baby or if the infant or fetus is still premature in nature. Number 5, placental problems such as placental previa or abruptio placenta. Number 6, severe PIH because your cardiac or your uterine contractility at times also increases your heart rate, thus increases your blood pressure in return. Number 7, grand multiparity because for grand multiparity, kumbaga sa athlete, expert na yan. They usually take a lesser time in order for them to expel the baby. That's why for grand multiparity patient, enhancers are not advised. Also, for patients who are pregnant or multi-gestational patients, multi-fetal gestation, ibig sabihin kambal, triplets, cause that might result to injury if you artificially induced contraction. Next will be history of uterine trauma in relation surgery to the cervix as well as over-distended uterus. For all of these factors might be worsened due to forceful contraction of your uterus during induction. Based from your learnings in your anatomy and physiology, your pituitary gland produces oxytocin, a potent uterine constrictor. Normal yun na napoproduce among our clients. However, you would like to enhance the production of your oxytocin by administering different oxytocics. Okay, number 1 is, oxytocin itself. Oxytocin facilitates smooth muscle contraction, which will include the contraction of your uterus. Okay, with the increased frequency and phase of uterine contraction, expulsion of the fetus is likely to happen. The objective of this is to have adequate contraction patterns that will promote labor progress. Ibig sabihin, dumadalas at lumalakas. We would like to avoid uterine hyperstimulation That's why in the hospital, we are administering oxytocin drips while they are on fluid regulators or infusion pump in order to adequately control their flow rate. Also, if cervical dilation is already 5 to 6 cm plus adequate contraction pattern has been observed, slowly terminate the administration of your oxytocin because that will only hyperstimulate your uterus. Because during that time na ma-achieve na natin yung 5 to 6 dilation, usually there is already an engagement in your fetal head sa ating ischial opening. With that will signal the brain to produce natural oxytocin na. Kaya nililimit na lang natin siya in order to prevent hyperstimulation. Why? Because in the event that there will be hyperstimulation of the uterus, there might be uncoordinated, untimely contraction of the uterus, which is not beneficial in any case. That might only result to tiring or excessive pain sensation in the maternal side as well as fetal injury in the long run. That's why for administration of your oxytocin, aside from incorporating it IV, we can administer it through IM immediately after placental delivery. Well, if you would not like to administer oxytocin, you can also provide non-pharmacologic ways on how to increase or stimulate the body by stimulating the mother's nipples in order to stimulate our hypothalamus, therefore contacting the pituitary gland to release more oxytocin. Next will be ergot alkaloids. This directly acts on smooth muscle receptors that decreases their stimulation. Not used during labor for it promotes sustained uterine contraction. That's why kailan binibigay ang ergot alkaloids? After the fetal delivery or even the placental delivery. It's favorable after the delivery in order to maintain sustained uterine contraction, to shut all those bleeders para mailabas lahat ng products of conception in order to prevent any hemorrhage or uterine involution. Okay? However, for ergot alkaloids, the following are your nursing considerations. Number 1, we would like to monitor the blood pressure of your patient after administering the medication. Mind you, you are not to administer ergot alkaloids if your patient are experiencing extreme hypertension because this will further increase the blood pressure of your patient. Next, do not give before placental delivery because this might cause increased injury kapag hindi pa nare-release ang placenta. Okay? Kailangan nating i-administer to pag na-deliver na ang placenta in order to, again, promote prolonged fetal or prolonged uterine contraction. Do not use with other vasoconstrictors. Observe for side effect, nausea and vomiting, dizziness, hypertension, dyspnea, and headache. Observe for ergotism. And lastly, among our oxytocics is your prostaglandin in the form of dinoprostone, which also promotes cervical softening as well as cervical aphasia. Well, that basically ends our discussion for this session where we have focused our attention towards the reproductive pharmacology or the medications that is involved during the pregnancy. We have talked about medications that are taken as supplements during the pregnancy, medications that answers the normal discomforts during pregnancy, namely morning sickness or nausea and vomiting, heartburn, and even pains. We have also specified medications in order to promote tocolysis or cessation of uterine contraction in order to promote maternal maturity, where we have provided or discussed terbutaline as well as magnesium sulfate. You have also discussed how we are artificially hastening fetal lung maturity with the use of corticosteroid therapy. Also, when the fetus or the child is being born with a premature lung, your surfactant therapy. You have also discussed management for pregnancy-induced hypertension in the form of your magnesium sulfate again and your hydralazine. You have also understood how pain is being controlled all throughout the progress of labor, our different analgesia as well as anesthesia, and also medications that are considered to be uterine contraction enhancers. Well, all of those are basic knowledge when we approach our topic, maternal and child nursing. That's why always keep into mind all those medications as well as nursing responsibilities that accompanies each medication. With that, I would like to leave you with my saying that whatever you do, learning should always be a fun experience. Goodbye everyone. Once again, this is Jonas. Stay safe. God bless.